So hey guys, today we are going to learn how to prescribe insulin in type 1 diabetes mellitus and what dose, right? So insulin regimen in type 1 diabetes mellitus. This is going to be a very quick video and we are going to have a very practical approach. I will first sensitize you with all the names and then I will explain you why they are called this and how to prescribe them, right? So let's go. Insulin are of four categories: 1, 2, 3, 4. The first one is rapid acting, and in that example are Lispro, Aspart, Glulysin. The short acting one is human regular insulin. The third one, intermediate acting, is NPH or neutral protamine head-gone or isofen insulin. Long acting one are Glargine, Digludec, and Datamir. Now to sensitize you with another, I will throw you another term, basal and bolus. Now this rapid acting, short acting insulin are used as bolus insulin, and intermediate and long acting insulin are used as basal insulin. Now why they are called this we will discuss later. Now to further throw you some more name and to sensitize you with the Indian practice and tell you the Indian brand names. The rapid acting is called rapid acting because they start acting in body within 15 minutes, right? And the first one is Lispro. The brand name is Humalog, and the half-life means for how much duration the insulin stays in body and works is 2 to 4 hours. And the route of administration is subcutaneously, right? So Lispro, Humalog. Aspart is Novorapid, the same half-life 2 to 4 hours, same route subcutaneously, nothing new here. Novorapid. The third one is Glulysin. Brand name is Apedra. Half-life is 2 to 4 hours. The route is same subcutaneously, and this all are rapid acting or called as bolus insulin, right? Moving forward to another bolus insulin, but it is short acting and its half-life is not more than the rapid acting ones, and it is 6. It stays more in body than the rapid acting one. And mind well, this is the only insulin which we give IV. Yes, it can be given subcutaneously or intramuscularly, but it is the only insulin given IV, and the brand name is Human Actrapid. And this is also the insulin given with combination with intermediate acting insulin, which is NPH, right? So Human Actrapid is very important. Now talking of NPH, intermediate acting insulin, right, is usually mixed with regular insulin, and the common brand name is Human Mixtard. And you must have heard about this combination 70-30, where 70 is NPH, act as basal insulin here, and for bolus coverage, here it is given 30 amount of regular insulin. It's a combination of two insulin, Human Mixtard, right? So it works in body till 12 hours. The long-acting ones act 24 hours. The short-acting ones act 6 hours. The rapid-acting works 2 to 4 hours. But the intermediate between of all this, the isofen insulin or NPH works 12 hours. Alright. Another exception of this insulin is that the dosing for mixed formulation will always be different. That is very common sense. Now coming towards long-acting insulin, which will stay in body for 24 hours, that's why they are given as basal insulin. The first one is Glargine, which is most commonly used, and it's also known as peakless insulin. It does not peak with its action in body, which you will see later. Because of its peakless action, there will be less chance of nighttime hypoglycemia, so we give it at night time. Alright, the brand name is Lantus. Glargine is Lantus. Degludec, another long-acting basal insulin, brand name Tresiba, also have no peak, right? No peak. Tetamere has peak, but it is also a long-acting insulin, works 24 hours and has peak. It's a basal insulin. Got it? The brand name is Levemir, given subcutaneous. Now forward to the main part, insulin regimen. The first regimen is going to be basal bolus regimen. And we will discuss about the human mixture. We talk about that dosing and how to correct the insulin in bolus insulin forms according to carbohydrate intake and quick method of calculation in emergency. Now, why there is a basal bolus? Moving forward to this basal bolus regimen, which mimics the normal insulin profile in a healthy individual. So, in our body, whenever we have breakfast, lunch, or dinner, we are going to have a postprandial blood glucose spike. But in a normal healthy individual, pancreas will secrete insulin and then decrease that blood sugar spike at every meal, right? So the red one is insulin, the blue one is the glucose spike that occurs in our body, and insulin maintains the homeostasis of our sugar level. Now in type 1 patient, there is a deficiency of insulin. So we have to mimic this normal profile in our patient by giving insulin externally at the same time patient is having meal to cover the postprandial blood sugar spike, right? So now we will give them bolus insulin, short-acting insulin bolus at every meal, breakfast, lunch, and dinner, right? These are the bolus insulin shot. And in night time in diabetic patient, there is hepatic gluconeogenesis. The liver produces the sugar from the biochemical pathway gluconeogenesis, and that can result in hyperglycemia in the morning, fasting blood sugar spikes. For that coverage, we will add long-acting insulin, which we have already discussed, glargine. So if we add an insulin which has peak, that will have a peak action in the night, and that will decrease blood sugar drastically at the night and will cause hypoglycemia. So that's why adding peakless insulin like glargine is very important in basal bolus insulin regimen to avoid fasting blood sugar spike and nighttime hypoglycemia. Alright? So the bolus insulin are for decreasing the postprandial and the basal are for covering the night coverage. Now, as you understood why we give basal bolus insulin, let's learn that rapid lispro-asparglucin are the bolus insulin which peak at 2 to 4 hours, right, and leave the body shortly. The short insulin peak at 2 to 4 hours and act till 6 hours in our body. The intermediate act till 12 hours, right, and the long acting works for 24 hours. See, you can notice here that the datamere is having peak, but the glargine is not having the peak. You can also appreciate here in this table that the rapid acting onset start in 5 to 15 minutes, peak at 120 minutes, and duration of action is 3 to 5 hours. The short acting will peak at 4 hours and will work in body till 5 to 8 hours. The intermediate will peak at 4 to 10 hours and work till 10 to 18 hours. But the long-acting Lantus, glargine, or Tresiba, degludec will not have a peak, so they are very preferred choice for night-type insulin or basal coverage, where Levemir will have a peak. So basal bolus insulin are added before each meal because they are rapid acting and have short half-life. And glargine and degludec are peakless insulin, so no nighttime hypoglycemia. And glargine will be our first choice for basal insulin and will given at night. Now coming to the dose section, you will take the patient weight, multiply by 0.3 to 1 unit according to insulin resistance of the patient or HbA1c value. That you will choose the scale of this formula, 0.3 to 1 unit. Now, if the patient weight is 50 kg and you multiply by 0.4, you will get 20 unit. That will be your total dose, the 100% insulin. Now you divide it by 2 and get 50% of the dose. Now that 50% will go to the basal part and the 50% will go to the bolus part, which you will again divide it by 3. One third, one third, one third will go at each meal, breakfast, lunch and dinner. Right? For example, patient is weighing 50 kg, you get this total dose 20 unit. You divide it by 2, you get 10, 10. The 10 will go to the basal, which will be your glargine, and the bolus, aspartate glucose, will be given 3 unit at breakfast, 3 unit at lunch, and 3 unit at dinner. Right? So that will be your insulin regimen for a patient weighing 50 kg, and you can correct it for every after postprandial meal. You will check RBS of the patient, the blood sugar level, and you can add 1 to 2 unit corrected insulin to cover better sugar control postprandial. Now the dosing of mixed form of insulin is different from basal bolus regimen, which is human mixed-ARD. And how you will do it is that the total dose you will calculate by the same formula. If the patient is weighing 50 kg, the total dose will be 20 unit if you take 0.4 value. So if you divide it by 1/3 and 2/3, right? So 2/3 of the dose, like 12 unit in this example, will be given in the morning because it will cover 3 spikes in the day, and 1/3 at the night time, which will be 8 unit. So here regular will play the role of bolus and NPH will play the role of basal insulin. Right? So bolus insulin can also be corrected by the carbohydrate intake of the patient in the meal. For example, every 1 unit should be added for every 10 gram of carbohydrate intake. Right? So now in a case scenario where you don't have so much time, you don't have HbA1c patient, you don't have any previous history of sugar levels. In emergency case, your RBS value will play main role. If that is 300, you divide it by 10, 0 will cancel out and you will get total dose of 30 unit. And then you have to do the same method with the basal bolus or a human mixed-ARD, and you will get the regimen of your patient. Right? So this was a very quick video. I hope you understood. Thank you. Please subscribe.